Hi, so today's lecture is about glaucoma, and I'll do less of writing and more of talking in this particular module. See, glaucoma can be divided into primary open angle glaucoma, primary close angle glaucoma, and secondary glaucoma. And then secondary glaucoma can be divided again into secondary open angle glaucoma or secondary close angle glaucoma. Now, the classification of glaucoma is very simple, but the definition of glaucoma itself is mistaken. It is not the increase in IOP. It is not the increase in IOP. It is actually the optic disc involvement that is actually glaucoma. It's not the optic. It's not the raised IOP. Okay, so if someone tells you that glaucoma is something to do with raised IOP only, you should know that the person is giving you half knowledge, because it's the optic disc atrophy or optic atrophy or neuropathy. Okay, optic disc atrophy, optic neuropathy. Okay, it can be because of raised IOP or maybe with normal IOP as well. So those are called normotensive glaucoma. Okay, or no. Okay, so that's just something that I really wanted to get cleared in the first. Now let's talk about the entire glaucoma step by step. And while talking about it, only we'll explain the concepts at that point of time, correct? So let's talk about primary open angle glaucoma. What is it? It is bilateral because it's primary. Okay, it's bilateral, symmetrical, increased IOP, causing optic neuropathy or optic disc changes, optic neuropathy. Okay, it's in old age, so you have to check for 50 years. And genes involved are MYOC, WDR36, and optineurin. Okay, no one will ask us, but this is just to show that there is a familial aspect to it as well. Familial as in family history is present, genes associated. Now, if a patient comes to you with increased in IOP because of primary open angle glaucoma, that means that the angle is perfect, correct? The angle is perfect. That's what I'm saying, right? That this is the cornea, this is the lens, and this is the angle, the trabecular meshwork. Okay, here is the trabecular meshwork. Okay, so this is normal. I mean, the angle is normal. Angle is normal. But there is a trabecular meshwork pathology where the trabecular meshwork has a lot of amorphous substances. Now, the amorphous substances is not allowing the drainage. Also, there's narrowing of the intertubercular space. That means in between each tubercle in the trabecular space, sorry, there is a certain space through which the aqueous humor can flow out, right? So if there is narrowing of the intertrabecular space, that means the space become really narrow. Okay, there is less flow, so narrow of the intertrabecular space. And third is also going to be that there's going to be collapse of the Schlemm's canal. Now, what is the Schlemm's canal? You need to understand that the drainage occurs in this manner. Obviously, the trabecular meshwork, okay, and from the trabecular meshwork, okay, it can be innermost, mid. It has the different parts. Okay, the innermost is the uveal meshwork. Okay, then the middle is the corneoscleral, because this is the cornea and this is the iridocorneal angle, right? So this is, and very important is that here also there is the sclera that continues. Okay, this is the cornea continues as part of the sclera. So the sclera begins at the iris, right? So it's the corneoscleral meshwork, and the outermost continues as Schlemm's. So what happens is that what I'm trying to say, this is not that important. The point that I'm trying to bring forth is simple. It drains from the trabecular meshwork, goes into the Schlemm's, okay, goes into the collateral channels, okay, and then into the episcleral vein. Okay, now this is into the episcleral vein. So this is the collateral, this is the Schlemm's. Now, if the Schlemm's canal collapses for some reason, obviously drainage is not going to occur. And now, because of increased IOP, there's going to be ganglion cell changes. So here you have here you have the optic nerve, and there's going to be increased pressure. Now, because of increased pressure due to IOP, increased IOP, as we all know that this is how the eye further continues. And because of increased IOP, okay, there is going to be decreased exoplasmic transport. Okay, this is going to be really slow. Okay, so first of all, there's going to be decreased exoplasmic transport, and because of that, there's going to be certain amount of optic neuropathy. Second is there is also going to be pressure associated damage at this level, which is also going to cause a lot of optic neurite or glaucomatous optic neuropathy. Okay, so there's going to be obviously stretch. This is the lamina cribriosa. Lamina cribriosa is out here. Lamina cribriosa is the scleral part. So the lamina cribriosa also dilated. So when they are dilated, the lamina cribriosa is something like a mesh. Okay, it is allowing all the neurons to pass through, and they are also dilated, and that's why they give as laminar dot sign on fundoscopy. Laminar dot sign on fundoscopy. Why are they dilated? Because of increased IOP, and there's mechanical stretch because the entire eyeball is getting stretched. So obviously this part is also going to get stretched. It's going to get stretched. Okay, but because of IOP also, there's going to be a lot of pressure changes, which is not going to allow the exoplasmic transport occurring. So exoplasmic transport is also reduced. Okay, the exoplasmic flow is reduced as the sclera compresses the axons. Now a very important point that I wanted to make was the signs of POG. When do you say that the person is suffering from POG, or what are the symptoms? First of all, let's talk about the symptoms, and then we look at the negative history as well. The symptoms are simple. You have headache, you will have delayed dark adaptation. Okay, why? Because the central fibers are affected, and the central fibers, uh, the more than the central, also the retinal fibers are also affected. So because the retinal fibers are affected, you can have that delayed dark adaptation, as rods are affected first. Also, what you want to understand is that a very important point is that there is scotoma that is seen later on, and there is obviously changes in the presbyopia, changes in presbyopic lenses. Why? Because there is changes in accommodation. Now this accommodation itself, okay, there is a lot of decreased accommodation that can occur. The accommodation is failing because of the increased IOP. So that's very important, as I feel. Now, what are the signs of IOP? When do you say that someone has IOP or a raised IOP? Simple. If the two eyes के बीच में, if the right and left, okay, the difference is somewhat around 5 mm. Or if it is night and if it's day, the difference is around 5 mm. Sorry, 8 mm of Hg. Here it is 5 mm of Hg between the two eyes. Or if both the eyes or any of the eye has greater than 21 mm Hg. Okay. What about the optic disc? When you look at the optic disc, okay, the optic disc, how does the optic disc actually show? The optic disc is something like this, and there is an optic. So there are two components to the optic disc. One is the optic disc and one is the optic cup. So optic cup is this, optic disc is this. Optic cup से क्या निकलेगा? Optic cup. The question is, how is the optic disc? How is the optic cup? Well, the optic disc. Okay, if you want to think about it, optic cup is where the neurons come, and optic disc is where the arteries are. Now what happens is that because of the stretching, the optic disc and optic cup becomes more vertical. Okay, and it becomes vertical. Okay, and the ratio of the optic cup and the optic disc now becomes more than 0.6. The average is obviously 0.3 to 0.4, but if someone asked you, the normal is all the way up to 0.6. So that's what I'm trying to say. Okay, once we've covered that, another very important point that I wanted to make is that the optic disc and optic cup, if you think about it, okay, so anatomy of the optic disc, if I show you the optic disc, okay, the optic disc is very important because the optic cup, okay, I think I kind of inverse the entire thing while teaching. The If this is the optic disc, okay, let's reject this. If this is the optic disc, okay, and if this is the optic cup is allowing vessels to enter. So this is the optic cup. Now the optic cup is allowing vessels to enter, and they are going to go supply the different parts, obviously. So we also have a very important optic cup. Okay, now the optic cup is allowing vessels to travel, right, to the optic disc, and the optic disc is having a lot of neurons. Now these neurons are arranged in a very peculiar manner. That means this optic disc, if you look at the retina, let's say we're looking at the retina and this is the retina, okay, and for some, and we flattened out the retina, it's a piece of paper. Now it's we flattened out the retina, we are saying this is the nasal side, we say this is the temporal side, okay, correct. So far so good. Now if you know about it, every eye, when you draw an eye, we always draw that the fibers are towards the nasal side, right? So that means that the nasal side should have the optic disc and the optic cup, correct. If the nasal side has the optic disc and the optic cup, that means the vessels are going to come from the nasal side. Now that means that here these are going to be the temporal fibers, correct. So this is going to be the superior arcuate fibers, okay, it's going to be the inferior arcuate fibers, or we can also say superior temporal fibers, or we can also say inferior temporal fibers, correct. So far so good, so far so good. So if that is the case, okay, so what is the nasal side of it? The nasal side of it, okay, the nasal side of it is called superior radiating fibers and the inferior radiating fibers. So which out of these fibers are affected in the end? Which out of these fibers are affected in the end? Superior is, if you think about it, the superior radial fibers, these are affected in the very end. Why? Because as I told you that the temporal field is affected in the end. Now the temporal field is definitely going to project from which side? Is going to project from the temporal field into the superior radiating fibers, and that is why the temporal field, if it's affected in the end, that means the superior radial field is affected in the end, correct. So far so good. So that is a very important point that I also wanted to make. I also made about the lamina dot sign, where there is stretching of the lamina cribiosa, and that's why we see lamina dot sign. Let's talk about also a lot of things like splinter hemorrhages. Because these blood vessels are coming out, you can also see certain amount of splinter hemorrhages. That's very important. Also very important sign is that because there is so much of an optic disc, an optic cupping, there's so much amount of optic cupping that what happens is, let's take a cross-sectional view. If this is the optic cup, okay, if this is the optic cup, usually if usually the optic cup is like this, and this is your optic disc as well, so the vessels directly just enter. Now what happens is that there is going to be a lot of twisting of the vessel, so this is called as the bionating sign. So it's called bionating sign. Just remember the sign, it's asked quite a few times, bionating sign. So bionating sign is also seen. So apart from that, we also see wedge shaped defects. That is, the optic disc is wedge shaped, so wedge shaped defects, and peripapillary atrophy. That means atrophy around the optic disc, as well, okay. So what are going to be the visual field changes? The first change that you will see is, you will see an decrease in visual field. So if this is the visual field of, if we are tracing the visual field of the patient, the decrease is going to occur, and the blue is going to be the decrease. So now the visual field is decreased, so this is called as isopter contraction. Second is that you're going to have bearing of blind spot. So your blind spot is somewhere going to line here, is somewhere going to be lined in the green, as I'm showing. Why? Because the optic disc is also somewhere out here. Now that means, yeah, but if I'm drawing it, so now if I'm showing that the blind spot is out here, that means what I'm indicating is that this is the nasal and this is the temporal. Because on the retina, the blind spot is on the nasal side, or is on the nasal retina, and this is the temporal. So obviously the temporal field is going to be affected. So now the temporal, this is the temporal side. Note that this is the temporal side. Note that these are two separate entities. This is the retina. Here I'm doing the visual field testing, or perimetry. I'm doing the visual field testing out here. So here is the blind spot in the temporal region. Now obviously there's going to be contraction, and there's going to be bearing of the blind spot. Now bearing of the blind spot has occurred. Now what happens is that there is also a very important next step, that is called as paracentral scotoma. Now central scotoma would be here, if there is a scotoma, if this is the visual field, and the scotoma would be in the center. Now this is the temporal and this is the nasal. What happens is that there is a paracentral scotoma out here somewhere, and that paracentral scotoma is a very important scotoma. Why? Because this paracentral scotoma now joins with the blind spot to form something called as the a sedal scotoma. So that basically is, if here is the blind spot, and this is the temporal and the nasal visual field, and here is this paracentral scotoma, what it does is that it forms kind of a sickle shape. It forms a sickle, and here you can see there's a sickle shape, sedal scotoma. Now once that is done, what happens is that now it further continues downwards. If this is the temporal, if this is the temporal, if this is the nasal. All right. So what happens is that there is certain amount of an arc form. So this is called as arcuate. Okay, this is called as arcuate or gerum scotoma. Gerum scotoma. It's called gerum scotoma. Correct. Okay. So far so good. So far so good. Now let's look at the now let's look at the very important question that we have out here. Right now, the question is that after this has been formed, there is something called as a double arcuate sign. That means if this is the center, obviously this is going to be the first arcuate, this is going to be the second arcuate, and there's also going to be a loss of congruency between between these loss of vision area. So what happens is that there's a double arcuate with a step defect, and finally this loss of central vision is also going to occur. So the central vision is also gone. Okay, and also there is certain amount of loss of nasal vision. All right, and what is spared is just the temporal vision. So the temporal vision is last to be affected. Okay, so far so good. So far so good. Okay, now as I told you that the normal blind spot is present in the is definitely present at the normal blind spot is present in the temporal field. Correct. Agreed. So when we saw from this area that the temporal field has a normal blind spot, and when there is contraction, there's an isoptic contraction. Okay, and there's bearing of the blind spot. That means everything apart from everything, the blind spot itself is not a part of the visual field. That means the blind spot is gone and the area around it, but yet there is certain amount of temporal vision that is yet present. Okay, so that is why I'm saying that the temporal vision is last affected. This is just a point that has to be noted. But the sequence is going to be simple. The sequence is going to be obviously first there's going to be isoptic contraction, a complete contraction, and then there's going to be a lot of blind spot changes, the blind spot, and then the paracentral scotoma, and then very importantly the arcuate. And first of all the sickle, then the arcuate. Sickle would be speedle, arcuate would be gerum, then you will have a double arcuate, and then you would have a step down, and then you would have loss of central field, and then the nasal field, whatever was left, and eventually even the temporal visual field. And that is about the PAOG. Now how do you want to treat this? Okay, now why have I gone into the visual losses and changes is because they ask the entire thing, and the treatment is going to be simple. You want to do a prostaglandin, beta blocker, and epinephrine. Now we'll get into this and alpha 2 agonists like apraclonidine, brimonidine, and then you can also do a beta agonist. Now what is the one that is used? Okay, now the beta, we could also do acetylcholine inhibitors, carbonic anhydrase inhibitors, that's acidazolamide. And the reason why I'm getting into this is that prostaglandin can cause macular edema. Okay, beta blockers can cause asthma or worsen asthma. Obviously it can cause blepharoconjunctivitis, nasolacrimal duct blockage. Corneal anesthesia is a very important question that is usually asked. Okay, E is epinephrine, which we do not use. Alpha 2 is apraclonidine, can cause drowsiness, apnea as well. Also apraclonidine and brimonidine, drowsiness, apnea, bradycardia, stuff like that. Also it can cause mydriasis. Why? Because of alpha 1 stimulation if you want. And eyelid retraction, follicular conjunctivitis if you want, follicular conjunctivitis. Okay, so these are the side effects that are seen. But the first drug that you give is a prostaglandin. If does not work, you give this beta blockers as the first line treatment. If yet that does not work and now you want to go for a netarsudil is a rho kinase inhibitors, decreases epinephrine outflow and also uptake, and also what it does is that it increases trabecular meshwork outflow. Now the surgical treatment you do, a very important is you do a laser trabeculoplasty. A laser trabeculoplasty is basically the a condition where you can use argon laser or you could use an Nd:YAG laser, and you use Nd:YAG laser to make trabecular selectively you make holes into the meshwork, and when you make holes into the meshwork you increase the drainage as well. So that's about the selective laser trabeculoplasty. If you want to do selective, you have to do it in the other prophylactic eye. Selective is usually in the prophylactic eye, where you only make holes in certain regions. Also, you can do trabeculectomy, where you're completely removing the trabecular meshwork and you've made a fistula. Also, another very important drainage method is called micro-incision glaucoma surgery, called as MIGS, micro-incision glaucoma surgery. Micro-incision glaucoma surgery. What you do is that you take let's say if this is the outflow tract, okay, if this is the outflow tract, okay, if this is the outflow tract, and here is the lens, and this is the outflow track. What you do is that you make a hole and you put a device. You put a drainage device to increase the trabecular meshwork outflow, and this is basically something called as a express mini shunt. We put an express mini shunt, and this express mini shunt is a heparin coated non-ferromagnetic titanium stent that's implanted in the into by a corneal incision, and that is basically allowing the drainage as well. You could also use a polyamide shunt, which is called as cypass microstent, and you can use a zen gel stent. Okay, a very important thing is that we have a glaucoma drainage devices or set-on surgery, okay, where it is done in refractory uncontrolled glaucoma. Okay, so we do something called as a glaucoma drainage device. We have drainage devices as well. So we have a micro incision glaucoma surgery, we have drainage surgery, we have trabeculectomy, laser selective trabeculoplasty, and we've also got non-penetrating surgeries like deep sclerotomy, canalostomy, where we are bypassing the trabecular meshwork. I do not really think that that's very important. I'll just go back to the drugs and I'll tell you which are the drugs that increase the uveoscleral outflow or the trabecular outflow. Then increase the trabecular outflow. First of all, PG increase the uveoscleral outflow. Okay, what decrease the aqueous production is they decrease the aqueous production. Beta blockers, epinephrine decrease aqueous production, alpha 2 decrease aqueous production. Then increase trabecular meshwork, or the trabecular meshwork is obviously your epinephrine, norepinephrine, and netarsodal that I also spoke about. They also increase the trabecular meshwork. Also, netarsodal also decreases the formation because they increase epinephrine, norepinephrine. Okay, so that is a very important point. I think you can listen to that part on 0.75x so that you get a complete idea on what are the different drugs that increase this outflow and the uvoscleral and the trabecular meshwork outflow. Now there are two outflows, but I think that is important to understand. One is the trabecular meshwork and the other one is uvoscleral outflow. Now the trabecular meshwork is the 90% and this is the 10%, but you know what, we use this as the most in the therapies, like by using latanoprost. Okay, so that's very important in my eye, that uvoscleral outflow is also a very important type of outflow. Now after that we have something called as a primary angle closure glaucoma, and primary angle closure glaucoma is basically the closure of the angle, right? So it's acute congestive glaucoma, and now it's in the lower age group. Okay, now it's seen in the lower age group, and what happens is that if the patient is in a mid dilated, if the pupil is in the mid dilated position or the mid constricted position, now let's say you're in a dark room or it's in a mid dilated position, what happens is that because it's in a mid dilated position, if this is the pupil and this is the lens, if it's in a mid dilated position, what happens is, okay, now listen to this. Okay, because it's in mid dilated position or it's in mid-diasis, what happens is that now it touches the lens, and when it touches the lens, it forms the very important relative pupillary block, which is called as apposition of the pupillary margin against the lens surface, because here there is apposition of the posterior pupillary margin against the lens surface. So this is called a relative pupillary block. Okay, now once the relative pupillary block has occurred, obviously there's going to be a lot of, now I hope you realize that this is going to be the cornea, okay, and this is going to be the ciliary tract, and this is going to be the ciliary tract and stuff like that. So what is going to happen is that there's going to be a lot of iris bombing. What's going to happen is that there's going to be a lot of iris bombing. So the iris is going to become something like this. Okay, it's going to be pushed out. Okay, and this is called iris bombing or iris bowing, whatever you want to call it. And then after that, also a very important point that I want you to note is that because of this iris bombing, this entire angle that is present is also obliterated, and that's why you can have an angle closure here. And once you have the angle closure, you will also have that here also there are certain amount of synechies that are formed. Here also there are adhesions that are formed. So basically you'll have iris bombing, a lot of iris damage that could occur. Your lens is here. There is a certain amount of bombing as well. There's a posterior. There could be a first. It starts as a posterior signing key. Now it becomes an anterior signing key, and now you'll have a complete PACG. Okay, there's something called as a PACS and there's something called as a PAC. Okay, so primary angle closure suspect is a patient who has a normal IOP, a normal optic disc, but there's apposition with greater than 3 quadrants. That means there is certain amount of apposition that has already occurred. Okay, there is there's going to be an iridotabacular corneal contact. That means the iris ITC contact basically means irido. That means that the iris, okay, is in contact with the trabecular meshwork, and is also in contact with the cornea. So irido trabecular contact. So let me make a good enough diagram. This is the iris. This is the cornea. So as you can see, it's in contact with the cornea. The trabecular meshwork is almost obliterated. And here is the lens. So this is an ITC contact, and this is a patient who has a PAC PS suspect. Simple है. It's a bilateral. Is it a bilateral? Well, it can be bilateral, but it can be unilateral, bilateral, and asymmetric. It's asymmetric. There's going to be a lot of pain. There's going to be nausea, vomiting. There's going to be redness. There's going to be halos. Halos have to be differentiated from the cataract halos. Check for if the halos are scattered. If it is scattered, it's cataract. If they are intact, scattered, it's cataract. If it's intact, it's most likely to be a PACG. Also check for the Walk-Trad. Walk-Trad is glaucoflecken. That is a cataract because of glaucoma. Anterior subcapsular cataract that we'll see in the cataract video. I'm going to make a cataract video too shortly. So there's going to be anterior subcapsular cataract. There's also going to be iris atrophy. Why? Because there's so much of an iris bombing. Also there's going to be a lot of pigment dispersion on the corneal endothelium. Okay, now a very important point that I wanted to make is there is going to be a stony hard eye because there's going to be increased special eye pressure is going to be above 40 mm of Hg, and this is a very this is a acute condition. It's going to be a eclipse sign is also going to be seen. Eclipse sign because of the angle being closed. What happens is that you show light into the eye. If the shadow is not seen, it's called an eclipse sign. Okay, the shadow has to be seen. If the shadow is not seen, that means there is angle closure. Okay, due to shallow anterior chamber, iris blocks the light. Okay, now if this is the cornea and this is the iris, okay, the shallow anterior chamber is going to block the light, and there's not going to be a lot of shadowing that's going to be seen. So that's basically the eclipse sign. And then we have a pupil which is vertically mid dilated and it's fixed. Okay, so the pupil is also fixed because of the iris and lens adhesion. Irido lenticular adhesions. Okay, and obviously the optic disc changes are seen, and on time examination the cornea is hazy. As the high IOP is also going to break the adhesions out here. Also is going to cause a lot of iris atrophy. There's also going to be posterior synechia, as I told you already, and there's going to be glaucoma flacken, which is the cataract in the anterior capsule of the lens, and the pupil is fixed, obviously, as I told you. And apart from that, there's a lot of ischemia and necrosis. Also there is a very important thing that I haven't spoken of, that there could be a corneal ulceration because of high IOP. Already we are seeing a lot of hazy IOP. We are also seeing a lot of hazy aqueous humor because of the endothelial damage. But now let's talk about corneal ulceration. There's also going to be staphyloma. Staphyloma is also going to be bulging of the entire sclera, and there's going to be atrophic bulbi, that's ciliary body atrophy. Now what is the treatment? What you do is that you reduce the IOP immediately, and what you do is the mannitol, or you can also do an acetazolamide. You give IV acetazolamide. Now if the step 2 is that you give pilocarpine and you make sure that the angle opens up. Now if the angle opens up, that's good enough, but if it doesn't, then you do an NdR glazer. Now you do an NdR glazer, and you do an NdR laser iridotomy. So basically what you do is that you make holes in the laser in the iris, so that the aqueous humor can directly enter into the anterior chamber without causing a lot of iris bombing. And if the iris bombing is treated, obviously the outflow is going to increase, because iris bombing itself is causing the shutting of the trabecular meshwork. So that is about it. There's a lot of congestion. So take that also in mind. And I think that is about when we are talking about the entire case. Okay. And then we look at the secondary glaucomas. And the secondary glaucomas itself, secondary, okay, the secondary glaucoma, okay, we look at the secondary glaucoma now. So the secondary glaucoma can be neovascular, inflammatory, and lens induced. Okay. So whatever type it is, we have to keep in mind that this is not this is the secondary condition. This is not primary. That means the glaucoma is not occurring as the primary case. Okay, it's the secondary case. There has to be something which is there, so we need to treat the secondary case. So the secondary case, let's talk about the first is the lens induced. What is something called as the phacolytic? Phacolytic means the lens is broken. The lens is broken, so where it does go? If the lens is broken, the lens goes down, it goes ahead. So what is it going to cause? It's going to cause primary it's going to cause secondary open angle glaucoma. Why? Because it's going to go and where is it going to go? It's going to get deposited in the trabecular meshwork, and it's going to cause closing. It's going to cause decrease in the outflow. So this is called as a phacolytic. What about the phacomorphic? Phacomorphic means that there's going to be shape. There's going to be change in the shape of the lens. Now, basically, phacomorphic is that when the lens has increased in size. Now, lens has increased in size. What's it going to cause? It's going to go pushing of the iris and forward, and when it causes pushing of the iris forward, there's going to be iris bombing, and when there's going to be iris bombing, there's going to be secondary close angle glaucoma, and this is called as secondary close angle glaucoma. It's caused by what? It's caused by intumescent cataract. What is it caused by? It's caused by intumescent, and intumescent cataract is a cataract when there's going to be swelling of the cataract. There's going to be swelling of the lens, so that's an intumescent cataract. Okay, so it's phacomorphic is caused by intumescent cataract, and it's causing secondary angle closure glaucoma. You want to treat it by laser iridotomy. You want to make sure that the swelling is decreasing, the outflow is normal, and so you just want to again stop the iris bombing, the same way how we treated a primary angle closure glaucoma. Now, what is a phacotopic glaucoma? Phacotopic glaucoma is again it occurs in the case of small and round lens, and when the small and round lens gets close to the iris, it closes the angle. Okay, it closes the angle. So again, so let me talk about the phacotopic, because the phacotopic is relatively more important, I feel. The phacotopic is when, okay, there's a Morganian cataract. Okay, it's a Morganian cataract, and what happens is that in this Morganian cataract, okay, let me explain the entire thing to you. Okay, so this is your lens. Okay, this is your lens, and now because of the Morganian cataract, the nucleus has fallen down. Now the nucleus has fallen down. Okay, however the capsule is intact. Now the nucleus has fallen down, the protein WBC all are activated. Okay, so there's going to be a lot of loss of anterior capsule, and there's going to be loss of anterior capsule, and they're going to get deposited in the trabecular meshwork. And this cataract that I'm talking about is something called as a phacolytic cataract. It's called phacolytic cataract. But the phacotopic glaucoma is actually the condition where the lens is going to shrink, and when the lens is shrinking, what it does is that it bulges through. It can bulge literally. It bulges through there can be anterior subluxation of the lens into the anterior chamber, and when there's anterior subluxation of the lens, okay, when there's anterior subluxation of the lens because of the intense fibrosis that has occurred into the lens because of the cataract, there can be anterior subluxation of the lens into the anterior chamber, causing phacotopic glaucoma. And now there's something called as a pseudo exfoliation glaucoma. It's a very common glaucoma. It's basically pseudo exfoliation is exfoliative syndrome. Is going to be exfoliation of the various substances, and what it's going to cause? It's going to cause secondary open angle glaucoma, and it's going to cause secondary open angle glaucoma by actually blocking the trabecular meshwork. Okay, it's simple. There's going to be all of the residues on the, let's say, the pupillary margin, the iris surface, the cornea, all of these ciliary process, all of them are going to go, and they're going to get stimulated on the trabecular meshwork. Also, what happens is that there's going to be also deposition on the anterior lens surfaces. There's going to be a target sign because of the exfoliation of the anterior capsule of the lens from certain regions. Okay, so that's very important. There's going to be a target sign. A very important sign also seen in the pseudo exfoliation syndrome is there's also going to be deposited on the papillary margin. These exfoliative things are going to be stimulated on the papillary margin, and therefore this is called as Knox sign. It's called Knox sign, and we've got a target sign. A target sign is where you have a loss of certain amount of material from the anterior capsule of the lens, and they're going to get deposited on the pupil margin. Also, there's going to be pure mydriasis. They're going to be poor mydriasis because there's going to be a lot of deposition out here. Okay, and there's going to be Sampoli's line. Sampoli's line is deposition of anterior to the Schwalbe's line. Now, what is the Schwalbe's line? Schwalbe's line is the line that marks the cornea and corneal sacral junction. So there's a lot of deposition that's anterior to the Schwal baseline. Now something called as the pigmentary glaucoma. Pigmentary glaucoma is secondary open angle glaucoma. It's actually the pigments that are getting deposited, so it's called pigmentary glaucoma. We've got two very important things. We've got Krukenberg's spindle and we've got Sampoli's line. Sampoli's line is the deposition of pigment ahead of the Schwal baseline that I've already spoken about, and the pseudo exfoliative. But there's something called as a Krukenberg spindle, and Krukenberg spindle are spindle that are seen on the corneal endothelium and trabecular meshwork. So let's talk about the Krukenberg spindle. Krukenberg spindle. Okay, that's very important. Krukenberg spindle is the deposition of the pigment on the corneal endothelium and also the trabecular meshwork. Okay, that's very important. Now after that, we also have something called as a inflammatory secondary glaucoma. Inflammatory secondary glaucoma, a simple inflammatory secondary glaucoma is divided into uveitic glaucoma, post-inflammatory glaucoma, glaucoma antiscleritis or poisonous Cosman syndrome, and Fuchs heterochromic iridocyclitis. So let's talk about the uveitic glaucoma. Uveitic glaucoma is due to swelling and dysfunction of the endothelial cells, and obstruction of the iris. So basically what happens is that because of inflammation, there's going to be an obstruction of the trabecular meshwork, and because of the trabecular meshwork, the WBCs are going to be there, and inflammatory precipitate. So there's going to be primary open angle, there's going to be secondary open angle glaucoma, sorry. So there's going to be secondary open angle glaucoma, and that's uveitic glaucoma. What about the post-inflammatory glaucoma? After inflammation, there's going to be a posterior synecdoche that is formed. A posterior synecdoche that is formed, which may cause occlusion of the occlusion or seclusion papillae, which can later lead to iris bombing and can later form a primary anterior synecdoche. Basically, what happens is that once the inflammation subsides, there's going to be also certain amount of adhesions that can be formed at the posterior iridolenticular surface, and when that occurs, there can be iris bombing, and again, iris bombing can cause iridocorneal ITC, that's iridotrabecular contact, corneal contact, ITC, and he becomes a PACS suspect. And when he becomes a PACS suspect, there's increased risk of secondary angle closure glaucoma. Now, what is glaucoma to cyclitic crisis or poisonous Cosman syndrome? So what happens is that there's going to be certain amount of mild uveitis. Actually, the disease is that there's going to be increased IOP. The increased IOP causes uveitis, and the uveitis causes glaucoma. So what happens is that there's mild uveitis, and in that mild uveitis, there is uncontrolled or unparalleled. There's going to be unparalleled level of increased IOP, and that increased IOP, okay, is also going to cause glaucoma. There is going to be very important to note is that there's going to be no anterior or posterior synecdoche, no anterior posterior synecdoche. So that means up till now there are very few conditions where we are not seeing a lot of synecdoches. We saw phacomorphic where we saw synecdoche. We saw phacolytic where there's subluxation. Phacotopic where there's subluxation. Phacolytic and uveitic are the ones where there are inflammatory debris. But now I'm talking about a very important condition called poisonous Cosman syndrome, or poisonous Cosman syndrome, also called as glaucomatocyclitis crisis. Okay, now let's talk about Fuchs heterochromic iritis. Fuchs heterochromic iridocyclitis. It's basically iridocyclitis, that means inflammation of the iris, and low grade iritis, and there's also going to be sub iritis. Okay, there's going to be low grade iritis, there's going to be sub capsular cataract, and there's going to be secondary glaucoma, Okay, now what is going to happen is a unilateral and a change in color of the iris. So the lighter iris is usually involved. Also, you need to understand that even in Horner syndrome, the lighter iris is usually involved. So the lighter iris is also usually involved, and this is called as Fuchs heterochromic iridocyclitis. And then we have neurovascular glaucoma, and because this occurs because in case of diabetic retinal occlusion or rubeolous iritis. And what happens is that basically there is going to be diabetic retinopathy or cerebral retinal vein occlusion or cerebral retinal arterial occlusion or any case of retinal ischemia. What happens is that there is going to be increase in VEGF, and increase in VEGF is going to cause choroidal artery proliferation, and the choroidal artery proliferation or the rubeosis iritis, and there's going to be rubeosis iritis, and this rubeosis iritis is what is it causing? It's what actually causing in a lot of blood vessels that are going to be present in the iris, and they're going to form a zip-like fashion. A zip-like fashion is going to be formed out here, and this zip-like fashion is going to cause adhesion of the iris to the cornea. Okay, there's going to be a lot of adhesion of the iris, there's going to be a lot of swelling, and there's going to be a lot of increase in the iris endothelium and the iris epithelium, and there's going to be adhesion, and there's going to be secondary angle closure glaucoma. Okay, and that's a symbol, and we have to do a lot of we have to coagulate the neovascularization. Okay, what is the steroid glaucoma? Steroid glaucoma is basically something where there is increase in the ECM, extracellular matrix of the trabecular meshwork because of steroids. Okay, so there's something called as steroid responders, there are something called as steroid non-responders, and that is basically about it. Now what is about the malignant glaucoma? Malignant glaucoma is a very important condition where there's going to be reverse, where you have to use atropine, and it's called reverse glaucoma because you have to use atropine. You have to use atropine to treat this particular condition. Now it is also called as ciliary block glaucoma, aqueous misdirection syndrome. What actually occurs is that during any particular laser iridotomy or any other surgery, laser surgery or NDAC surgery or incision, NDAC or incision, what happens is that what actually occurs is that this is the normally, this is the iris, this is the lens. Okay, here is the ciliary body, and here the aqueous humor flows in this direction. But what happens is that post surgery what actually happens is that the lens is posteriorly subluxated. That means here is the ciliary body, okay, and the lens is out here. So what happens is that the lens is the lens is present anteriorly, and posteriorly is the ciliary body. So what happens is that here there's going to be accumulation of a lot of fluid, and this lens iris moves forward. Because of this, the anterior chamber is made shallow, and the anterior chamber is also made shallow, and it's posterior and there's a lot of secretion that's present in the posterior chamber. Now that it cannot actually enter from the posterior chamber into the anterior chamber. Okay, and there's pushing of the entire system leading to angle closure glaucoma, and then this is closed, and there's going to be increase IOP. Okay, because the entire angle is closed. Now this angle has been closed because the lens and the iris itself is pushed forward. So how do you want to treat it? Why do you want to use atropine? You want to use atropine because you can relax these ciliary muscles, and when you relax the ciliary muscles, what happens is that these fibers relax the suspensory ligament. They become a little they become a little taut, and what happens is that the lens falls behind. Right now, when the ciliary muscles they are contracted, the suspensory ligament they are also in the relaxed state, and the lens is is ahead. Okay, so there's going to be stretching of zonules, and there's going to be pulling back of the lens. So that's why we use atropine. Usually atropine would make all the PACG worse, but this is the only SACG, the secondary angle closure glaucoma, where atropine can be used. All of this has to be done on the 0.7x speed because it's at very high speed. Okay, and childhood glaucoma is again newborn, infantile, juvenile, and it can be primary congenital glaucoma. Primary congenital glaucoma is a condition where there's going to be increase in IOP. There's going to be increase in IOP, so you're going to have blepharospasms. You're going to have photophobia. Very important is there is going to be photophobia. There's going to be lacrimation. Now what happens is that there's going to be a hazy cornea. Why is there going to be hazy cornea? Because of increased IOP. Okay, there's going to be a hazy cornea. Also, there's going to be buff thalamus. Buff thalamus is going to show scleral thickening, and there's going to be a blue eye. Buff thalamus. Okay, and also there's going to be myopia because of this entire stretching of the cornea. And also there's going to be a very important triad called as Hobbs striae. Hobbs striae are concentric or horizontal breaks in the descendant membrane, and this is very important because secondly, this is a primary congenital glaucoma, and its onset is less than 3 years, and the mechanism is that there is going to be trabecular dysgenesis, that the trabecular meshwork is malformed and the angle is usually open. So it's a primary angle closure glaucoma, which is actually congenital. And the symptoms are simple, going to be blepharospasm, photophobia, and also there's going to be a lot of lacrimation. And that is about it. Buff thalamus is something that is very important to understand. Thank you very much. Let's see you later in the next lecture of cataract.